Katy Lees, Principal 340B Compliance Advisor with Virtue 340B. How is everyone doing? This is episode 4 of my video series. We are calling this Katy's 340B Compass. I hope that those of you that have watched some of the other videos have found them to be helpful. Today I wanted to talk a little bit about current events in the 340B program. So today we learned of a court ruling. I think it actually occurred yesterday, but a federal judge in the District of Columbia has ruled in favor of HHS, and I'm calling it in favor of covered entities everywhere, to uphold HHS's ability to limit manufacturers from unilaterally implementing a 340B rebate model. So awesome news. I know it is not winning the war. This is not the end of the road, but we won this battle. We will take victory for today, for sure. So awesome news, and not to put a damper on it, but I just wanted to talk a little bit about what this means. Not today's ruling, but what this implications of implementing a rebate model could mean for covered entities and ultimately, I guess, healthcare across the country, based on what it could mean for covered entities. So first, I was gonna talk about just a little bit of background, how we got here, super quick. There's way more detail than I'm gonna share here, but there's many sources to get all of this information and talk about the court drama that's been happening over the past 5 years and all of the parts of it. So I'm just gonna touch the highlights. Starting in 2020, the pharmaceutical industry started to push back on participation in contract pharmacy arrangements. So I touched on this, I think it was in my first video where we just talked about 340B in general. We talked about contract pharmacy. I didn't really feel like I did a great job of explaining it then. I brought a friend with me today. I mean, not a friend, but a tool that I thought might be helpful. Sometimes I'm a very visual person, so I think that sometimes it helps just to have, a picture to put with what we're talking about. So here we have this contract pharmacy diagram, just to walk through how a contract pharmacy arrangement works. But over in the upper left-hand corner, this is our covered entity. So our covered entity is writing a prescription for a patient who subsequently takes it to the pharmacy. Here's our pharmacy over here with two pills on the top of the building. This medication is dispensed to the patient. Now behind the scenes, this covered entity and pharmacy have a contract relationship where essentially the pharmacy is filling a prescription as an agent for the covered entity. Maybe they don't have their own pharmacy. Maybe they do have their own pharmacy, but they just have a very large region where they're providing care to patients. And so it benefits them and their patients and to some degree the pharmacy for these arrangements to exist. So now they have this contract arrangement where the prescription has gone to the pharmacy, it has been filled and dispensed to a patient, and it's determined that this is a patient of the covered entity. They received their care we'll call it the hospital. They received their care at this hospital. This care resulted in the prescription that was being dispensed, and the pharmacy did that business for them. So as a result, because of this arrangement, the revenue collected on the prescription is paid to the covered entity. This is minus a dispensing fee that's kept by the pharmacy, which that dispensing fee on average is going to be a little bit better than maybe the margin they would make on that prescription on their own, because obviously they are a business and it needs to benefit them as well. And then in addition to this financial exchange, the covered entity purchases the drug from the wholesaler, and this drug is replenished to the pharmacy to replace the inventory that was used for that prescription. So what makes this a beneficial transaction is that when the covered entity is purchasing this drug, they're purchasing it at the 340B cost. So that's what makes this a transaction that works for all of these parties to be involved. And then the entity is invoiced for the drug because the entity is purchasing the drug. Technically, the ownership of that drug is with the covered entity, but it's replenished and put back on the shelf for the product that the pharmacy used to dispense that prescription. So that's very simplified version of a contract pharmacy arrangement. But I mean, while it might be more complex in how it's administered, I mean, that is the basics of a contract pharmacy arrangement. So in 2010-ish, the HHS had determined that covered entities participating in the 340B program could expand their ability to contract with pharmacies. And there was no limit to the number of contract pharmacies that they could contract with. Prior to that, there had been a limit to 1 per covered entity. That was an area of growing discontent between covered entities and I guess the federal government and the pharmaceutical industry, that this growth in the program was very problematic. And I think in addition to the growth in the program, it's the lack of transparency that the pharmaceutical industry has, to identify prescriptions that are involved in these contract pharmacy arrangements versus the ones that are not. So a combination of those was brewing for many years, about a decade. And in 2020, a couple manufacturers, 1 or 2, the second and third quarter of 2020, decided that they were going to take action, and they released a policy to covered entities saying that they were no longer going to support these contract pharmacy arrangements, that covered entities, all the policies, again, which started in 2020, but I guess I should say over the next few years grew to, I believe we're at almost 40. I want to say it's 38. But I stopped counting after a while. So more than 30 pharmaceutical manufacturers over between 2020 and 2023 or 24 have implemented policies where they have restrictions on covered entities' ability to purchase drugs at 340B pricing for replenishment to contract pharmacies. This, again, I'm giving a very simplified version of this story because there have been countless lawsuits, there have been court rulings, this has been a lot of drama in the contract pharmacy program over the past 5 years. And basically that has resulted in not only that, but that has brought us to where we are now of facing the same drug manufacturers, at least some of them, wanting to change these upfront 340B discounts to a rebate model. Meaning that instead of the covered entities being able to purchase a drug at 340B pricing to bring in to administer to any eligible outpatients of their hospital or health center, those covered entities would have to purchase the drug at full price, wholesale acquisition cost. There's various requests of data. It will depend on the drug manufacturer, what information the covered entity would need to submit, and even what vendor or platform this process would work through. But they would submit associated data with that wholesale acquisition cost purchase and how the covered entity used that drug. And after that information is submitted and gone through a validation process, then the covered entity would receive a rebate, which would supposedly be equal to that upfront discount that they receive today. So it's very complicated. I'm not even sure I did a good job of explaining that there, but in late 2024, I believe it was August of 2024, we saw our first official rebate policy proposal come from Johnson & Johnson. It was for 2 drugs, Stelara and Xarelto, and that policy was released to covered entities similar to these contract pharmacy restrictions that we have become accustomed to over the past 5 years. And it stated that for those 2 drugs, effective October 15th, covered entities would have to make any purchase for Xarelto and Stelara at wholesale acquisition cost, and then submit that purchasing data along with the associated utilization data to a third-party platform, the Beacon platform, for it to be evaluated and determined if the covered entity is entitled to a rebate that, again, would be somewhat equivalent to the 340B discounted price that they would pay today. So HHS, HRSA quickly condemned that, said that Johnson & Johnson does not have the right to unilaterally implement a rebate model like this, and that they threatened that Johnson & Johnson would have their agreement with HRSA and participation in the 340B program revoked, which, if you know the background on that, and if you have viewed my initial video, the participation in the 340B program is directly related to participation in the Medicaid and Medicare program. So those two drugs, or I guess all drugs from Johnson & Johnson, would have no longer, or potentially no longer, been covered by the Medicaid and Medicare program, which would obviously have significant implications. So they did withdraw that policy. Not long after, filed a lawsuit against HHS for preventing them from implementing this rebate model. And then another company, Sanofi, also released a model after that. It went through a similar process. That was not limited to 2 drugs, and it actually included a request for a third data set, which would be the patient encounter data that went with that associated the utilization and purchase. And then there's 3 other companies that did not go through that same process, but did follow through with litigation against HHS for not approving a rebate model. So we have 5 companies that have expressed that they want to move forward and transition from upfront 340B discounts to this retrospective 340B rebate model. And that brings us to today, our victory. And that we learned that one of the courts was actually hearing 4 of those cases, all as a combined effort. And then actually one of the vendors in the space as well was part of that lawsuit. So the judge has ruled that HHS was within their rights to not approve these rebate models. So definitely not the end of the road, not the last we heard of it, and we may still have rebates in our future, but again, today we are taking that victory. So more so what I wanted to talk about again is that, what's to come. We really need to be talking about what these rebate implications could mean for covered entities. Everyone needs to understand what this will mean for your institution. And even, I hope that any decision that happens that comes down from the government, that they understand. If we have no control over what happens, I would at least hope that when the government is making a decision, that they're armed with all of the right information, that they have all of this information on, financially, operationally, just what this would mean administratively for everyone and how this needs to play out if we're going to make any changes to the 340B program. So I don't know how much detail would be helpful to get into here. I just really wanted to talk about this and raise awareness. I think everyone in the 340B space is fairly aware. But there's, different levels. I know there's certainly different covered entities probably have different levels of awareness and have done different levels of analysis to understand what this would mean for your covered entity. This would mean if any company is allowed to implement this rebate model, the ones that have been proposed, it's not limited to contract pharmacy. It's for every 340B purchase that covered entities make. So again, the Johnson & Johnson was limited to 2 drugs, but that was in every setting that those drugs are used. And the Sanofi one was not limited to 2 drugs. And again, it was in every setting that those drugs were used. This will have huge implications if we move to a rebate model. And there have been rumors, which I think are stronger than just hearsay rumors, that as soon as one company gets the green light for this, there's 20 companies waiting in the wings, ready and willing to switch from upfront 340B discounts to this retrospective rebate model. So this is going to be a landslide, very similar to those contract pharmacy restrictions that started in 2020. And then quickly we were at almost 40 manufacturers that had these restrictions in place. all with different policies, all with different expectations that we had to meet to minimize the financial and operational impact that these policies have had on our covered entities. This is going to look exactly the same way. This will be chaos if we don't either stop it, or, maybe the more realistic thing or approach that we need to be thinking about is, how can we find some place to collaborate? And I know that's a tricky thing, and many people don't even want to go there, but I do think we need to be talking about it. We need to get stakeholders together, and we need to talk about, is there some middle ground? Like, what could we live with? I'll say, I don't know if any covered entity is going to say they can live with any sort of rebate model. I'm hard pressed to talk about that at all, but I will, because we have to. We can't just put our head in the sand and say, absolutely, this can't happen, because what if it does? Like, we need to be at the table. We need to be talking about it. We need to be educating all of the right people to make sure that whatever does happen, that it happens in a way that is not completely devastating. So I actually did just put together, I needed to get all of these thoughts out of my brain and onto paper. So I wrote a document just on all of the implications and challenges that I know about. And I probably didn't capture all of them, but just tried to put it down on paper so that it could be a tool for me when I'm talking about this topic, or for anyone else that, might want to know more about this, or wants some, a document to be able to give to others as a resource to better understand what these things would do. The argument from the pharmaceutical industry and supporters of the pharmaceutical industry is, what's the difference? We'll get you your rebate in 7 to 10 days. Well, I don't think that's possible. And I don't know what that means, because 7 to 10 days from what? If the covered entity buys the drug today, what if they don't dispense it today or tomorrow or next week? Do they still get the rebate within 7 to 10 days of buying it? Or do they get 7 to 10 days from when they submit all of the data that accounts for a full package of a drug? Or is it after the third-party vendor is able to take the purchasing and utilization data and reconcile it with the billing information? So, once that prescription or that medical claim is billed and paid for by the third-party payer, is that reconciliation step that's going to be that final validation that a rebate can be paid within 7 to 10 days from that? No one is going to sell me on the fact that covered entities are going to have this rebate back in time to pay their bill to the wholesaler for this full price drug that they had to buy, that today they buy it at the discounted price that they've been federally entitled to for the past 30 years. So, again, I, at least personally, I don't speak for all covered entities, am open to, talking about how do we collaborate? How can we do this? There can be more transparency. When these contract pharmacy restrictions started, one of the asks of the pharmaceutical industry was, we want the data. If you provide the data that supports your purchases and replenishments to contract pharmacies, then you can have access. And while most covered entities showed up to that dragging their feet and complaining all the way, and we said we were doing it under duress, that was a solution that really did work. That was the transparency that gave, theoretically, the pharmaceutical industry what they were looking for. So, we were able to access the drugs at 340B pricing to benefit our organizations, to care for patients, to provide medications at a lower cost, and to provide services that just consistently lose money. In exchange, the pharmaceutical industry knew the prescriptions that were resulting in those 340B prices. So I argue, and again, this is myself, Katy Lees, not necessarily speaking for, covered entities as a whole, but I think that a good solution is some sort of data sharing, is some sort of clearinghouse, but it still needs to include upfront 340B discounts. I mean, we can't just immediately swing so far to the other side. That's such a complicated process, and there's just way too much at stake for us to have to purchase everything at wholesale acquisition cost and then have this process to reconcile the data and, you know, pay out these rebates that we may or may not be able to reconcile, you know, on the back end. And it just really would complicate things from a financial aspect. It will be so challenging from a technological standpoint. I talked about the data sharing, the Second Sight's platform, 340B ESP, which was the site that was managing all the data sharing and still does on some levels today. You know, that has had a really big learning curve. I mean, I don't want to speak for them, but I have to imagine that they know that they've learned a lot through this process, that they promised so much to the manufacturers that they were supporting at the beginning that they really had no idea what they were signing up for. The manufacturers that were asking that for that information had no idea like how challenging that was going to be receiving all of this information and trying to reconcile it with the rebate data that they received from Medicaid and other in PBMs. So it's very complicated. It has been a process. And I think that that can work on some level. I think that we can have some sort of neutral clearinghouse. Neutral, it needs to be something that is administered by the government, not by a party that has a bias to, you know, one of the other stakeholders, covered entities, pharmaceutical industry. It needs to be administered by the government. You know, maybe it can be a contract similar to what Apexis plays, you know, as the prime vendor to HRSA. But we have to, you know, we have to come together. We have to talk about, you know, what can we live with? What can we absolutely not live with? I don't know. I feel like I'm just rambling now, but this is a really serious matter. So I just thought that it would be a good topic for today, since again, it's a good day. We are not gonna, you know, see rebates implemented tomorrow, but I feel like it's a win today, but I don't see it. You know, I don't know what the long-term future is. So we have to be talking about this. We need to find a place where we can all just collaborate and find a solution that works, that will not devastate the safety net providers of our country. You know, whether or not I know people can't agree that the 340B program, you know, works all the time or is working as it was intended over 30 years ago when it was implemented. I know that there's stakeholders that absolutely feel like it's not. I'm not saying I'm one of them, but I get that. But it still is one of the core elements supporting our healthcare system at this point. So, you know, we cannot pull the rug out from under that. We have to find a solution that works. So I hope that we can do that. I have some faith that we can do that. Let's just start talking. Let's start trying to work together. I hope that the HHS is going to, you know, find a meaningful process to evaluate all of this. I know that as part of that, the court case that just ended, I know the HHS, I think it was on May 2nd, did tell the court that in 30 days they would issue some sort of guidance on these rebate models. I hope that it will be, you know, something like a request for information. Let's ask stakeholders some really valuable questions. Let's find out, like, reasonably or feasibly, what is the solution that will work for covered entities, and also, you know, give the pharmaceutical industry something that they can also live with. So I hope that we can do that. Again, I feel somewhat optimistic. Let's just start talking. Let's try to work together and see where this can go. And I'm sorry, I hope this wasn't rambling too much. I hope it was helpful. Always open to hearing everyone's comments. Feel free to comment, send me some questions, and I will be back soon to talk about something else. Thanks, bye.